Shall we start?
Sounds good.
Great. Well, thank you everyone for connecting. Good afternoon. It's a pleasure for me to introduce the first year's site presentation. In this case, we will be discussing the PDA catheter closure protocol, and it will be presented by Dr. Adrianne Bischoff. Dr. Bischoff is a clinical assistant professor of pediatrics and neonatology at the University of Iowa State Family Children's Hospital. She has expertise on hemodynamics, physiology, target neonatal echocardiography, and she has research interest on PDA, asphyxia, meconium aspiration syndrome, and extreme prematurity. For the panel discussion, we will be joined by Dr. Valerie Chuck. Dr. Chuck is an associate professor at Stanford and is leading NHRC investigation. She has expertise developing both clinical and research application for neonatal NHRC, including assessment of infants with hypoxic ischemic encephalopathy, congenital heart disease in the perioperative period, and neonates with a patent Ductus arteriosus. We will also be joined by Dr. Shyam Sathanandam. Dr. Shyam is an associate professor at the University of Tennessee Health Science Centers and medical director of the Interventional Catheterization Laboratory, and it's well recognized for his clinical and research work with ductal closure in the preterm newborn. And last but not least, Professor Patrick McNamara, professor of pediatrics, neonatology, and cardiovascular medicine, director of the Division of Neonatology and Pediatrics at the University of Iowa State Family Children's Hospital, chair of the Pan American Hemodynamics Collaborative, and co-chair of the Oversight Committee at the NHRC. So thank you very much, Adrianne, for your presentation.
Thanks, Daniel. I was asked to present today on what the Iowa experience has been so far in terms of PDA catheter closure. Our program here in Iowa started in October 2019. That was when we did our first neonate that was in the unit, cath closure. Cath closure, and ever since we've had very few actual surgical PDA ligations, and those were restricted to babies that were actually quite small and or unstable to move to the cath lab. So that has been the majority of the babies that we've had definitive closure. Let me see if I can move my slides. There you go. So here you can see that there's been several changes in practice towards the most recent years. This is data from the Canadian centers where the number of surgical ligations, similar to here, has dramatically decreased in the 10-year period. And that has been substituted by a significant increase in the practice of percutaneous or transcatheter PDA closure. And the graph on the right is from the Memphis group, which again shows the substantial increase in the number of caths that are being done in the past few years. And these shifts have to do not only with the changes regarding practice, regarding PDA management itself, with a more kind of conservative approach, but also because of the inherent risks that are associated with the invasive procedure, particularly surgery, as I've listed down there, a couple of them. Here at Iowa, we have referred since October 2019, 62 patients to the cath lab. The majority of them were under 2 kilos. Sorry, it's not showing up, but 56 of our babies were less than 2 kilos at the time of the procedure. We had 5 patients in which there was technical failure, and one of our patients died of a pericardial effusion and a cardiac tamponade. We had 2 patients that had access difficulties. One was unable to cannulate the femoral vein, and there were suspicions for clots in the femoral vessels. And the other one, the femoral vein was successfully cannulated, but then there was an IVC thrombus that was seen and the catheter could no longer be advanced. And those babies were all referred for traditional surgical ligation subsequently. And then we also had one patient earlier on, right at the first stages of our program, that went to the cath lab. And even before cannulation, he got an echo, and the PDA at that time was deemed to be too small for closure. So that baby actually came back to the unit, got an additional course of medical therapy, and didn't require any definitive procedures. Out of the 57 babies that were successful, you can see that I've listed there the majority of side effects. So we had about 30% of overall adverse events, and that's encompassing for all of the things. The majority of them are actually quite mild and have no impact on the baby's overall health and don't require any management. Those are predominantly mild gradients because of some protrusion of the device into the adjacent structures, but also mild residual shunts and transient tricuspid regurgitation. There was one baby in which there was an embolization to the right pulmonary artery, which was successfully retrieved. So there was no major complication from that standpoint in the cath lab, but the PDA was deemed to be too large and there was no device that was appropriate for the closure. And that baby was also referred for surgical ligation in the end. We've had, like I said, procedure-related mortality of only one patient out of the 62. And we had one more baby who died several weeks after due to a complication that was unrelated, which was a bowel perforation. Here I put some examples of what these adverse events associated with the procedure are. This is an example of one of the residual shunts. You can see the piccolo device in white here in the picture, and there's some red flow going through it. This was the most significant one that we had. The other two were actually quite small residual shunts. This is a patient who developed a new onset tricuspid regurgitation, which you can see with the arrow. That's the jet in blue. This is likely because of some injury at the valve while the catheter is entering the right ventricle. And this TR resolved within a couple of weeks as well. And this is the most common thing that we see, which is when the device protrudes ever so slightly into the left pulmonary artery and causes a little bit of flow acceleration. But this also tends to improve with time as the baby grows. We haven't had any baby who required manipulation of the device, removal of the device, or any procedure for stenting the LPA or anything like that. So how does this work here at Iowa? Because of the complication that we've had and the one patient mortality and also the FDA approval for size, we only refer babies at this moment who are at least 700 grams. Having said that, because sometimes it takes a little bit of time to coordinate cath lab availability, sometimes we will refer babies that are slightly smaller with the prediction that by the time that their cath lab date is set, that they will be closer to the 700 grams. We try to ensure that there are no other confounding conditions for why the baby might have failed medical therapy, and that's particularly infection. Just about 2 weeks ago, we had a baby that was set to go to the cath lab, but the outputs were quite high on echo, so we ended up screening the baby for infection, and the baby had a high CRP and had basically a ventilator-associated pneumonia that wasn't quite prominent at the time. So we had to postpone the procedure until the infection was under control. We always liaise with the interventional cardiology team about the morphological suitability for percutaneous closure. We haven't had any concerns about this, but always ensuring that the PDA is not one that is too small or that the pulmonary artery end, which is where they enter for the procedure, is not too small. Like I said, we had one baby that by the time the baby went to the cath lab, they wouldn't have been able to cannulate, but now we know better and that has not happened anymore. More recently, also because of the two babies that we've had with difficulty access, we try to pay a bit more attention if there's any history of thrombosis, particularly IVC or liver. We don't routinely go looking for that, but if there's any concerns, we sometimes have done ultrasound of the vessels prior to sending the baby. And then the next part, of course, and most important, the comprehensive assessment of shunt volume and significance. So the way that we do here, and this is not a cookie cutter approach, but this is just to give you an overview of what our most normal approach is for the babies. We screen with targeted echo all the babies less than 30 weeks. The smaller ones, we screen at 12 to 24 hours of age. The ones that are a little bit more mature, we tend to screen a little bit later in the first week of life. If they have congenital heart disease or heart dysfunction, that follows its own protocol and management plan. However, if there's PDA, if the PDA is a low volume shunt, we repeat the echo as clinically indicated and depending on the patient's course. For the small ones, sometimes that means scans every couple of days to make sure that the PDA is actually closing and not becoming more significant. And for the ones that have moderate or high volume shunts, we start with medical therapy. Here at the University of Iowa, Tylenol is our first line for babies in the first week of life. Indomethacin is used after 1 week of life. And the majority of babies that are referred for cath lab tend to have at least 2 or 3 failed or relapsing remitting courses of PDA shunt. Like I said, this is not a cookie cutter approach. Sometimes depending on which medication the baby has responded previously or not, we might modify to sometimes 2 courses of Tylenol versus 1 of endo, but that's kind of the overall approach that we take with repeated medical therapy. When I mean shunt volume, what we use is a comprehensive TN echo assessment, and we look at what we call the modified Iowa PDA score. You can see there that it takes into consideration left heart volume loading markers, including left LA to AO ratio, the mitral E, and the IVRT. We look at the pulmonary vein velocity, particularly the D wave. We look at the ratio between the left and the right ventricular output as a surrogate of QPQS. We look at the impact on the systemic vessels, if there's any reversal of flow to the descending aorta, the celiac, or the middle cerebral artery. And although it's not officially included in our PDA score, we take into account the size of the PDA indexed to the weight, because a 1.5 millimeter shunt may not seem too big, but when the baby is 500 grams, that's actually a pretty large duct for that type of baby. And we overall, it's like I said, it's a comprehensive assessment, but we tend to call a moderate volume shunt when the PDA score is at least 6 out of the 12 points, because we don't typically give points for the PDA size indexed to 8. So how do we prepare the babies for the procedure once the referral has been made and once the decision is to proceed with definitive closure? One of the things that we always include in our pre-referral assessment is arch-sidedness to make sure that that's not a sling, and confirming the ductal patency and the suitability for percutaneous closure. We try to do an echo not more than 72 hours prior. So if the baby got referred at the end of the week, and the cath closure is only going to happen in the middle of next week, we repeat the echo before sending the baby down to the cath lab to make sure that everything is still looking the same, to avoid a trip and then finding out that the PDA has suddenly closed or that it's too small now for closure. Here we do secure vascular access for all of our patients, preferentially with a PICC line, and we try to have a PIV access for emergency and for any blood transfusions that might be required during the procedure. We always do a CBC to make sure that the baby is not anemic or thrombocytopenic. And as kind of a routine, if the baby is not already on chronic steroid therapy, we do a rapid ACTH stim test to take a look at what the adrenals are doing. As part of our unit guideline, we do hydrocortisone stress dose and maintenance for all of our babies at this point in time. And we do antibiotic prophylaxis for 24 hours around the procedure. Having said that, we recognize that this is a clean procedure and it's intravenous access under ultrasound guidance. And we are mindful of the fact of the nephrotoxicity of these antibiotics, particularly in babies that are preterm, that have prolonged renal underperfusion because of their PDA, and who are also undergoing contrast fluoroscopy. But for now, that's what we have been doing here in our unit. And on the night before of the procedure, we always have inline medications ready if we need it for the post-procedure period. That includes morphine for sedation, Mirinone, and epinephrine, and I will talk a little bit more about that later on. If the baby is a little bit older and no longer has an umbilical arterial catheter, we consider putting a radial arterial line. We choose radial and not posterior tibialis because of the nature of the procedure and the fact that the legs are covered during the procedure. And we don't do that necessarily for all of the babies, but we do for the ones that are at higher risk for developing some instability post-closure. We also do respiratory optimization in the unit. For those of you who do not know, here at Iowa for the premature population, high frequency jet ventilation is our primary mode of these babies. And we send pretty much 90% of our babies on the jet to the cath lab, but that requires us to optimize things before we send the babies down. So we always check that the endotracheal tube is in a good place with the morning x-ray. We do our own sedation and muscle relaxation in the unit, and we start the morphine infusion to keep the baby relaxed for the transportation. And then we adjust the ventilator settings after the baby has been muscle relaxed here. And that's just to avoid any further drama in the cath lab and just make it easier transition for the anesthesia team that will be handling these patients. When we transfer the babies to the cath lab, we have our own approach by putting the jet on the right side that makes sense and easier at the time that the baby gets to the cath lab. All of our babies go on an overbed with a transformer and a hat, and they are accompanied by a multidisciplinary team, which includes the bedside nurse, the fellow, and a respiratory therapist. Most of our procedures are done in the morning, so the night fellow is in charge for sedating and optimizing the ventilation so that the baby is ready to go in the morning. We send a senior, so usually a third or at least a second year fellow or a hemodynamics fellow to accompany the patient and stays throughout the duration of the case for all of the babies who are on the jet or the ones who are high risk. We send boluses of morphine, Ativan, and vecuronium if needed during the transport, although it's barely ever necessary. And for the babies who are on the jet, we request that one of our respiratory therapists stays during the case in case any ventilator adjustments are needed, particularly after the PDA has been closed. In the cath lab, we are always mindful of mobilizing the baby very carefully, making sure that we hold the breathing tube while we're changing from the overbed into the cath lab table. We put the arms up, which helps to ensure easy access to IV for medications and to the arterial line for any labs that might be necessary in conjunction with the anesthesia team. We have a very good relationship, and we have a couple of anesthesiologists that have been doing this with us for the majority of the cases. So the process is quite streamlined at this point. We use the bear hugger for temperature control, making sure that these tiny people are warm in the cath lab. The procedure, once it starts with a limited transthoracic echo done by the cardiology team, which is to confirm that the PDA is there and get some measurements. And while we are getting that done, the interventional cardiology team is usually working on the femoral venous axis, which is ultrasound guided. During the procedure, transthoracic echo is used again to confirm the placement of the PDA, make sure that there's no protrusion into any of the adjacent structures prior and after the deployment of the device. And if there's any need, we can sometimes take an X-ray at the end, which I always instruct the fellows who are accompany these patients to take a look at the ETT and see if the compliance has already improved dramatically, and that if they need to change the ventilator settings even prior to coming back to the unit. The major risks while the baby is still in the cath lab, and Sham can probably comment on that in the panel later, are the potential for arrhythmia, for bleeding, IVC dissection, and of course, worst case scenario, cardiac perforation and tamponade. What is most common that we've seen is a transient change in the vital signs, either immediately after the deployment, usually in looking like higher FiO2 or a transient drop in the blood pressure, or while the catheter is still going through the pulmonary artery, that might happen as well. But if there is any instability, we always have the possibility to do kind of an X-ray while the baby is in the bed, and we have a gas machine so we can check if we need to do any changes on the ventilator. I don't want to go too much in detail because people have probably already heard me talk about this, but we have an approach because of the potential for post-closure cardiorespiratory instability, which is it's a disease of high afterload with secondary LV failure that traditionally was described as systolic hypotension with or without the need for inotropic support, plus impaired ventilation and oxygenation. In the presence of a significant left to right PDA, as you all know, there's pulmonary overcirculation, and the LV is exposed to a relatively low afterload since the PDA is connected to a low resistance circuit of the pulmonary vasculature. Once the PDA is closed, significant changes in the loading conditions happen, and therefore there's a reduction in the left heart preload, but also an increase in LV afterload, because now the LV is exposed only to the systemic vascular resistance. And these changes will eventually lead to a lower left ventricular output. The impairment in LV systolic performance tends to coincide with clinical deterioration. This is all data from the surgical studies, but the table on the right is from our own data here of part of our babies who went to the cath. And you can see that there are changes in left heart volume loading measurements and in LV systolic and diastolic function within the first hour after the procedure. So this is an example of a preterm infant. So this is an apical 4-chamber view showing a very dilated heart because of the PDA shunt. And 1 hour after the procedure, you can see that there's less volume loading and there's reduced LV systolic function. The immediate cardiovascular changes that happen after PDA closure include an increase in diastolic blood pressure, which is reflective of the loss of the systemic steal from the PDA. And there's some concomitant increase in systolic and mean blood pressure. And what you can see on the graph on the right is data from the patients that go through percutaneous closure from our group. And you can see that the diastolic blood pressure rises immediately after cath and continues to rise over the next 24 hours. It's important to know that in infants who develop post-closure cardiovascular instability, the typical course is that after an initial period of stability with higher blood pressure in comparison to the baseline, there's a progressive decline in the systolic blood pressure. And what's important to see is that the mean blood pressure remains relatively stable because the diastolic is still normal or high, which is important for the clinicians that are at the bedside to pay attention to all of the components of the blood pressure. And if this window goes unrecognized, which is typically after 6 to 12 hours of the procedure, the disease progression is characterized by a subsequent decrease in all of the components of systolic, diastolic, and mean blood pressure because of LV failure. And I always like to highlight that it's not any type of hypotension that fits the phenotype of post-closure cardiovascular instability. Specifically, early hypotension in the first 1 to 2 hours and predominant diastolic hypotension are not really part of the spectrum of this disease. And this is the primary, if this is the primary pattern that you are seeing, then other causes need to be taken into consideration. To show how these changes in loading conditions affect the LV, you can see that the majority of the infants fall into the flat part of the Frank-Starling curve, where they go from a volume loaded left heart to a condition of normal loading. However, if you have a patient who has relative hypovolemia before PDA closure, whether that's secondary to significant fluid restriction with or without the use of diuretics, then the change in preload would cause immediate decompensation after PDA closure, which is not what we typically see. So here we do write our babies for a total fluid intake of at least 140 or 160 per kilo per day, unless the baby was already on a lot more than that prior to the procedure. And I recognize that I have a very diverse audience here, and fluid management is very variable amongst institutions. And also for everyone who's watching, bear in mind that here at Iowa, our babies are not on incubators. So our fluid management may be a little bit different from most of you. On the other hand, the effect of afterload on heart function depends on sustained exposure leading to a low cardiac output state, particularly in the infants that have more vulnerable and immature myocardiums, which explains the clinical manifestations that are seen as part of the post-ligation cardiac syndrome spectrum within 6 to 12 hours after PDA closure. Moving on to the respiratory impact, the cessation of the left to right shunt is accompanied by an immediate improvement in lung compliance. So you can see that on the left is the x-ray of the baby in the morning of the procedure, and on the right is the x-ray of the baby as soon as the baby arrived back in the unit. But you can see that there's also, for example, this study from 2004 that shows that the ventilator parameters also improved quite substantially with the improved compliance. However, the respiratory instability is the second part of the spectrum of post-closure cardiorespiratory instability. And the proposed mechanism is related to diastolic impairment with secondary increases in left atrial pressure, pulmonary venous hypertension, and secondary pulmonary edema. So what we have noticed here in the patients after percutaneous PDA closure is that the respiratory phenotype of PLCS is much more common and prominent than the traditional cardiovascular instability. So these x-rays are an example of one of the patients in our cohort. You can see that prior to the procedure, the patient was on conventional mechanical ventilation in 35% of oxygen with very hazy and congested lung fields. Immediately after PDA closure, you can see that there is a substantial improvement in compliance. The lung fields are much clearer. But over the next 12 hours, the patient continues to develop progressive pulmonary edema with both oxygenation and ventilation failure, requiring escalation in the mode of support to high frequency ventilation. In this graph, we separated the babies here from our cohort according to the development of the composite outcome. And you can see in the darker gray bars that there is a significant increase in both mean airway pressure and FiO2, or here combined, a significant increase in respiratory severity score, particularly after 6 to 12 hours following PDA closure, which is the same time frame that has been described in surgical ligation. The risk factors for PLCS, as traditionally described, were lower birth weight, lower weight at the time of the procedure, as well as postnatal age. This graph is very interesting because it shows that the risk of PLCS in surgically ligated patients goes from as high as 50 to 60% when it's performed in the first week of life and drops to less than 10% if it's performed after 30 days. And this is an important consideration when looking at the various studies about post-procedural instability, because you have to consider these things in the context of the baseline risk. So if you describe, for example, a low incidence of PLCS post-percutaneous closure in patients that are 1.5 kilos and all 30 days or more at the time of the procedure, that's not particularly surprising because of what we already know about their baseline risk. Also in the original surgical ligation studies, left ventricular output at 1 hour correlated with left ventricular output at 8 hours and was associated with low systolic arterial pressure and need for inotropic agents. And that provided the groundwork for the use of early prophylactic Mirinone in infants with low left ventricular output after PDA ligation. So this was an EPOC study that showed a decrease in the need for postoperative inotropic support and a drop in the incidence of PLCS from 44 to 11% after the institution of a protocol using targeted Mirinone prophylaxis. Since Mirinone is a vasodilator, inotropic, and lusitropic agent, it is a biologically appealing medication for a disease that is characterized by increased afterload, impaired LV performance, and diastolic dysfunction. In our personal cohort, and this is not including all of our patients, although it was not statistically significant, the babies who developed instability were a bit smaller and had worse lung disease at baseline. And like I said, our study was done extrapolating the use of early targeted Mirinone prophylaxis that we were doing for the surgical patients. And you can see that there is a very high use of Mirinone prophylaxis in our institution, where approximately 70% of our babies end up qualifying for that, which is kind of a caveat to this type of study, because we can't really determine what would be the true incidence of instability if we had a completely untreated population. I'm sorry, my thing is moving by itself. When we looked at several relatively standard echo parameters, the LVO at 1 hour continued to be a predictor for the development of instability, even in this treated population that we have here. Similar to our study that looked at a population that was treated with Mirinone, this group found that the pre-ligation isovolumic relaxation time, which is a marker of LV diastolic function, was associated with a higher risk for respiratory instability. And while our study here hasn't really corroborated this finding, this does raise a couple of questions regarding the risk and the therapies that are needed to prevent this condition. I'm going to skip a couple of these slides about other potential risk factors so that we don't waste too much time on physiology and we go more for the practical aspects of PDA closure and our protocol. So in terms of post-PDA closure care, the things that we pay a lot of attention, first of all, is the new lung compliance. So as soon as the baby returns to the unit, we do a chest x-ray to make sure that the endotracheal tube is in the right placement, check what the lung inflation looks like, and we do a gas, and then we adjust the ventilator and frequently have to wean the mean airway pressure as appropriate. We immediately turn off the morphine sedation. Like I said, this is kind of like a PICC line procedure, so it's not really painful. We only use the morphine infusion to keep the baby calm and sedated for the transportation and to make it easier to do the procedure. But once the baby comes back to the unit, we typically turn that off pretty much right away. And then we do a targeted neonatal echo 1 hour post-closure, which is to guide the need for Miranone prophylaxis. If the baby does qualify for Miranone prophylaxis, we give a normal saline bolus during the first hour of the Miranone infusion, which is to counteract any potential vasodilation. And we do have a size-specific guideline for the dosage. Typically, we started at 0.33, but for the really small babies, sometimes we start at a slightly lower dose of 0.2. We also pay attention at weaning the hydrocortisone over the next couple of days because we do use hydrocortisone empirically for all of our patients in order to avoid any iatrogenic systemic hypertension. And then after we have done about half of these patients, we also started doing a routine chest x-ray about 6 to 12 hours post-closure. That was based on the fact that despite our Miranone prophylaxis approach, about 50% of our babies were having increased mean airway pressure and higher FiO2 needs. So we're doing x-rays preemptively to take a look at the compliance and try to capture those babies earlier and make any ventilator adjustments that they may require. The other important things to monitor is the trend in systolic and diastolic blood pressure. We give a lot of attention to any significant changes in the systolic particularly, even if it's not really meeting hypotension thresholds based on gestational age. We monitor labs for end organ perfusion with gas, lactic acid, and urinary output. For the babies who remain persistently hypertensive, even after Miranone, specifically if it's diastolic hypertension, we sometimes will titrate the dose to try to prevent them from getting in a place of too high of a blood pressure. And like I said, we watch very carefully the changes in respiratory status, particularly increases in FiO2, worsening of lung aeration on chest film, and increased ventilator requirements. So I wanted to finish off my presentation with a little bit of a less theoretical note and a bit more of a practical resource about how we manage these babies here with things that we learned and the expected physiology. So kind of as a recap, in the patients who develop early or diastolic hypotension, this is not the typical spectrum of post-ligation cardiac syndrome. And we need to consider other causes and address other causes, including need for volume resuscitation, if there are any other medications that may be vasodilators and any drug interactions that may occur, if the baby could be potentially overexpanded, or if there's any other complications such as pneumo or hemothorax, although we have not seen that here. Adrenal insufficiency for us is kind of covered because all of our babies do get hydrocortisone empirically, but that's something to take into consideration in your institutions if that is not done routinely. And in the cases where the hypotension is persistent, refractory, or severe, we may discontinue or reduce Miranone if the baby was on it. For those who have systolic hypotension or signs of low cardiac output, if we have availability, we can consider doing a targeted neonatal echo. If it's mild or if there's no one available immediately, we empirically treat as presumed left heart dysfunction, and therefore we start dobutamine or low dose epinephrine for inotropic support. We always get an X-ray, make sure that the device is in the right place. We want to make sure that the device has not migrated, particularly into the aorta, and that could be causing kind of a pseudo coarctation type of physiology. So always get an upper and a lower limb BP for kind of triage. And importantly, if it's predominantly systolic hypotension with signs of low cardiac output, if there's not dramatic diastolic hypotension, we keep the Miranon going, and this is not an indication to start that medication. The baby has systemic hypertension, especially if accompanied by respiratory symptoms. Like I said, we try to be a bit more preemptive about weaning the hydrocortisone. We may use a little bit of sedatives if needed intermittently, and we can consider increasing the Miranon that the baby is already on. And for those who develop clear respiratory symptoms, we do an X-ray and adjust the vent settings as needed. Always take a look at the device placement. Of course, chest X-ray is not the gold standard, but it's a very easy way to check for things that may be grossly different from when the baby returned from the cath lab. We may consider diuretics to kind of clear the pulmonary edema. Importantly, acute pulmonary hypertension is quite uncommon in these babies, at least in the age that we are doing them here. And if there is any underlying pulmonary vascular disease that was not known or not obvious prior to the procedure, that usually becomes quite obvious in our first echo. And therefore we can guide the team about what to expect. If there's any case of acute isolated hypoxia, we always keep in mind the potential for device embolization into one of the pulmonary arteries. And like I said, especially if the baby is hypertensive, we can sometimes consider giving a bit of a higher dose of Miranon. I think that's about it that I wanted to share. This is our group here at Iowa, very intelligent people that I'm very lucky to work with. And I welcome any questions that you guys may have.
Thank you so much, Adrianne, for that great presentation. If I could have all the panelists turn on their videos. I'll have some questions. If you have any questions, please do put them in the Q&A box and we'll start answering those. So a couple of questions, Adrianne, that has come up for you, and then we'll direct them to the panel as well. Are there risks for post-procedure thrombus formation due to foreign bodying the PA? And on that, do you all utilize heparin post-cath? As one question. And then there's a question, hydrocortisone. You're mentioning the hydrocortisone and whether all patients have prophylactic hydrocortisone initially, or do all patients just put on it during time of procedure? So the first question for the thrombus formation and heparin.
From what I've done we've done a meta-analysis together, and that has not come across as a known complication as far as I'm aware, but I don't know if Sham would like to comment a little bit further on that specific question of clot.
Yeah, thanks, Adrianne. Thanks for that question. We have not seen thrombus formation. We don't use heparin during the procedure or after the procedure. We were doing ultrasound of the femoral veins and IVC post-procedure for about the first 40 cases. We've done over 300 cases now from the NICU. For the first 40 cases, we did ultrasounds and we didn't see any thrombus, so we stopped that practice. I must say that I've seen one patient, there was some kind of a echo brights, not look like a clot, but almost like a membrane in the pulmonary artery. And that patient, I placed her on Lovenox, and this happened like several weeks after the procedure. So we placed her on Lovenox, not knowing what it was. That structure kind of persisted, but she was totally asymptomatic. After 6 weeks of Lovenox, we just stopped it. That's the only patient that comes to my mind that we considered some form of anticoagulation. But yeah, we don't use heparin either during the procedure or after the procedure. Having said that, we do flush the catheters using heparinized saline. And the heparinized saline has about 2 units of heparin per cc, and we use very minimal flush. That's the only type of heparinization the patient gets. Thanks for that.
Thanks, Sham. In regards to, I see that there's a lot of questions about the hydrocortisone use. This is a very unit-specific preference that we have. It was kind of an agreement within our own group, and it has to do with our own population, we have a lot of 22 weekers and very aggressive use of hydrocortisone early on. So the group felt strongly about the potential for adrenal insufficiency in the more immature patients and has decided to do that as a practice for all of them. Having said that, I do come from Toronto, where we did not do that approach for all of the patients. We would just do an ACTH stim test and have that information in the back of our minds, should there be any significant deterioration post-procedure. So there's not an absolute reason for that, other than this is what our group has decided to do and kind of get that out of the equation using hydrocortisone for all of our patients.
Can I add to that just a little bit? Given being part of the same program, I think the hydrocortisone is a hangover from the era of surgery. So this was a center where empiric hydrocortisone was used as a post-inflammatory agent to mitigate instability. And as Adrianne has pointed out, you know, we don't know an awful lot about the immature adrenal gland. Kind of when we looked at this in Toronto, it appeared to be around 10 to 12% of these babies seem to have an adrenal gland that doesn't work, but there were not a lot of 22 and 23 weekers. Now, I would say, which is even more interesting, we actually just looked at the Iowa cohort, and one of our cardiology residents has got very interesting data that when we looked at the hydrocortisone treated population here, and we looked at the rate of post-ligation cardiac syndrome, it was almost identical to what we saw in Toronto in an untreated population. And when we actually plotted out the probability graph, which looked at the relationship of postnatal age to the likelihood of instability, again, this is in the surgical population, it was like a mirror image. I couldn't believe how similar it was. So in terms of, are we advising people to give hydrocortisone? No. I think this is something that probably at a certain point we will relook at this, because from a biological perspective, you're not cutting the skin. There may be some babies that the stress of the procedure that might put them at risk of some adrenal gland issues. But I think we need to look to centers that do not use hydrocortisone empirically after cath closure. And if they don't have a lot of instability, I think we should potentially readdress this. But again, we have a lot of 22 and 23 weekers here, which it was, I would say, a decision made more by fear than a decision made by science. And there's nothing wrong with that. You know, practices change, things evolve over time. So,
if I may add, no, we don't use hydrocortisone routinely. Except when it comes to those, as you said, the 22, 23 weekers, even in them, if you're doing the procedure in the first 2 weeks of life, that's when we considered using hydrocortisone. A couple of things we've learned is once the corrected gestational age is 26 weeks and over, so if it's a 22 weeks, when they're 4-week-old, they tolerate the procedure so much better. So if their corrected gestational age seems to be less than 26, that's when some hemodynamic instability seems to happen from the procedure. The other thing, what at our center we've done is we try not to have absolutely no hemodynamic instability during the procedure. What we've seen is the patients who have any form of instability during the procedure are the ones who are unstable after the procedure. So we've come up with a set of criteria which by which we try to keep these patients heart rate, blood pressure, saturation, and temperature absolutely rock solid stable throughout the procedure, and that seems to make the biggest effect, because we don't see the hemodynamics changes afterwards. I think that's because it's totally reflective of what happens during the procedure. If the procedure makes a patient unstable, then the patient can have some hemodynamic compromise post. But our last 100 babies or so, we keep the patient so stable that we don't see the post-procedure changes.
Thank you all for
I didn't go into a lot of details about the post-procedure instability, but from our numbers here, out of the 62 babies, I can recall probably only 2 or 3 that actually had hemodynamic instability and required pressors or had very obvious LV dysfunction on echo. Like I said, the majority of ours, it is a substantial amount, it's about 50%, do have increased respiratory requirements, even though we are doing the Mironone approach. But hemodynamic instability is actually quite rare.
And on that theme of post-procedure issues, there's a question about 2 episodes of neck that developed immediately after PDA closure. One X-ray from cath showed pneumotosis of portal venous air. Valerie, with your work on NIRS and end organ saturations, is there a role for NIRS, or do you utilize NIRS on the pre or peri-cath PDA closures?
Thanks for that question. I think it just prefaces by saying, I think you obviously have to use the resources that are available at your institution. And we're fortunate at Stanford, there's very neuro-NICU as well as hemodynamic focus on our preemies and with the PDA. So we've actually incorporated NIRS monitoring to look at end organ saturations, both for diagnosing which ducts are hemodynamically significant in addition to the echo as well, and could potentially benefit from intervention as well as in the post-intervention phase. So I think it's really interesting about this question about neck, for example. We've also utilized NIRS to in those babies that are at risk for acute kidney injury, for example, that have a PDA. So especially the renal saturation, we see significant drops and significant variability in these kids with a significant duct that then is maybe the impetus for us to go on and say, this is the kid that needs to be closed. That being said, we also tend to do our definitive closure maybe a little bit later than other places because our focus has been conservative management in the early period. But even afterward, after cath closure, I think it would be really interesting if your center has NIRS to kind of see what are the end organ effects, because it's a real-time measure and maybe that could be incorporated into what can be done. Like if you're starting to see a decrease in your renal sats, is that the kid that you want to take a closer look at? Is this a kid that's at risk for neck, for example? Is this the kid that you want to change your fluid approach? So I think that would be a really interesting tool to add to the arsenal if it's at your disposal.
Thank you. I want to ask Adrianne, we've all read with great interest the Iowa approach, but in other places in the world, we're not used to the micro preemies. So just to have a little bit of context, how many of these babies received other steroids like dexamethasone? I don't know if some DARTs in order to try to extubate, or are in diuretics before the procedure?
Yeah, thanks for that question. Typically, our most common approach, of course, there's variability between practitioners, but if we think that the PDA is one of the major contributors to the ongoing need for respiratory support, we try to deal with that first. And that's usually using medical therapy or going for definitive closure. We don't typically will give DART or try to extubate if we still think that the duct needs to be dealt with. And diuretics usually come later in the phase of the care of these patients, not during active PDA physiology.
Amish.
Hi, Adrian. Excellent talk, and it's really interesting to actually see your data.
Amish, we can't hear you.
Sorry, can you hear me now?
You're very quiet. It's a very atypical thing.
Well, I've matured. I've gone older. No, I was just saying it was very interesting to see the data and the presentation you made and the physiological concept that you shared that were very enlightening. I have a sort of slightly more conceptual question, and perhaps for you and all the panelists, and something I struggle with quite a bit. There is a tendency, and I'm just being a devil's advocate here, and some of my colleagues ask me this question. The more you look, the more you find. This is not to say that we shouldn't look, that makes you blind. But obviously, if we look too much, we're going to find things which might be subclinical or transient. For example, in an echo done post-ligation, the patient is doing well, but the LV is dysfunctional. And we find almost obligated to end up treating those patients with something in balance. And that happens in our centers too. With the comprehensive protocol that you have, and you guys have, how do you handle that doubt or do you have a doubt? I do.
Yeah, that's a good question. I think one of the main things that we have started noticing after doing all of these babies was primarily focusing a lot on the left ventricular output and the extrapolation of the number that we chose for the cutoff of 200 that derived from not only a different institution with different practices in terms of fluid management, as well as PDA management and timing for closure, but also from surgical to PDA closure. Because here at this institution, if we use the cutoff of an LVO of 200, like we did traditionally, we end up giving Miranon to about 75 to 80% of our babies, which is much more than you guys were doing in Toronto in the surgically ligated babies. So we've kind of relaxed a little bit of our approach in the most, looking at more comprehensively at other markers. So if the baby has a left ventricular output that is a little bit more borderline, 180, 170, we try to look at some other markers for diastolic function, for systolic function, as well as the risk profile of, is this a young baby? Is this a small baby that is at higher risk? And we've hold off on starting Miranon prophylaxis specifically for some of these more borderline babies. But it's hard to change the practice when we also have a little bit of fear of having more instability if we don't do it. I don't know if Patrick wants to add anything else about that.
I think what Amish is getting at, I think is important, is that it's really, really important in whatever work that you do, drawing parallels between the clinical situation and what you might see on the echo, and not losing sight of that fact. You know, we always get surprises. We see a baby that suddenly you do an echo and you've got pulmonary hypertension, okay, and the baby is pretty stable, or you see X, Y, and Z. How does one define thresholds for intervention? And the only answer to that question is either one, a strong correlation with some clinical metrics of instability, or number two, an association of that finding with some important outcome that one wants to mitigate against, you know, and you know, as I said, our thinking is very much influenced by what we learned from the ligation population, but I think it's really important to be thoughtful, you know, about the relationship of instability to what you might see on the echo. And I think the piece that troubles me the most about the cath closure, and I think everyone is saying the same thing, we don't seem to see hypotension, hemodynamic instability, but there is an adverse respiratory trajectory that some of these babies get in the presence of fairly significant clinical hypertension. And it's very easy to keep increasing the ventilator because ventilators make ventilation stuff better. But drawing an association that this may be of cardiovascular origin, I think is important, because I think we're very naive if we think that all lung diseases of lung origin, all cardiovascular diseases of cardiovascular origin, and making sure that we constantly look at the relationship of the heart and the lung. But again, I think that Amish's comment I'm going to interpret very philosophical and meaningful from a research perspective, that it's very easy to see stuff on echo and to see stuff and not to get carried away with interpreting that it is pathologic without drawing some clinical parallels. I think that's the key point. I have just a question. I think we can answer the question, but I think that the question about neck post PDA closure, in my experience, both in Toronto, having seen a lot of babies, and also here, the one thing that's common to infants who have neck very early after PDA closure is prolonged duration of shunt exposure. These are babies that have had a shunt for a long time. It tends to not be infants that have their PDA ligated at 2 weeks or 3 weeks. And I just wonder, is this a vulnerable bowel that then suddenly is hyperperfused or reperfused, and then you get a problem? So the issue may be less about the intervention and more about the fact that maybe we waited too long.
Thank you, Patrick. I think we have time for one more last question. It's been a great discussion. There's a question in the chat, and as we're talking about the utility and the increased use of cath closure, how often or what percentage of your Iowa patients via BWs are actually getting the cath closure? Is there more of a likelihood that you all are sending these kids for definitive closure by cath rather than when you had surgical ligation?
So it's hard to say here at Iowa comparing just surgical to cath, because there's also been the introduction of the neonatal hemodynamics team and the early PDA screening protocol and our slightly more aggressive approach to the PDA early in life. So if you compare the two epochs, pre-hemodynamics and post-hemodynamics, there's actually been less referrals for definitive closure overall. But that has happened concomitant with the increase in cath closure and the decrease in surgery. What I can say is that right now, out of all the babies that we've definitively closed since October 2019, we've probably had only 4 of them who were surgical closures. And before that, they were all surgical closures, but the rate of definitive closure was much bigger pre-hemodynamics than post. So it's hard to say.
So the current data pre-2018 was in infants less than 27 weeks gestation, I think it was 48%. Now it's 18% that actually go for an interventional closure. But I know if Valerie wants to comment on her data from the NRN in terms of surgery versus cath and the trends that we identified.
I think it's very similar, actually, Patrick, to everything that you've already showed. Hopefully that'll be presented at PAS, but again, very similar in the increasing rate of cath closure and decreasing rate of surgical ligation through the network.
Well, thank you very much to all our speakers and to our speakers and panelists here today. We will be continuing with site presentations over the next few months, and our next site presentation will be March 16th, same time at 2 p.m. Eastern Time. The topic will be interesting cases on atypical neonatal pulmonary hypertension. Speakers will be Dr. Monteser, Dr. Patel, Neil Patel, and Dr. Hui Chen from the Scottish Neonatal Hemodynamics Group. So thank you all for participating today, and we hope to see you next time.